really rules out for the time being a benign cause, right?
Okay.
That's the main thing you should put forward to make a diagnosis of gastric malignancy, right?
Okay,
Okay.
sir.
How will you investigate the patient?
Okay, sir. First, the basic investigations, we would do a routine complete hemogram, blood sugar, urea levels, serum creatinine,
Okay.
serum electrolyte levels, and blood grouping typing, X-ray chest, and ECG.
Sure. In this particular case, in your general examination, what are the abnormalities you would like to expect in a case of CS stomach with gastric outlet obstruction? One by one.
Sir,
Yes.
yes, sir. There will be epigastric mass.
No, that's a finding. You said you are going to do some general examination, right? Hemoglobin,
Yes, sir.
VSR,
Yeah,
blood urea serum creatinine. What are the abnormalities you would expect in a
the
case of?
hemoglobin may be reduced, sir, because of the bleeding.
Very good. And
And
malnutrition as well. Yes.
yes, sir, malnutrition.
Okay.
And
Yes, one
sir,
second. I think those who know the answers can put it in the chat box. Weak location said pallor. That's right. Okay.
yes,
So
sir.
in general investigation, you are rightly told hemoglobin will be probably be reduced. Okay.
Yes,
Anything else?
yes. And in serum electrolyte, there will be hyponatremia, hypokalemia, and metabolic alkalosis.
Very good. Okay.
Hyperchloremia too, sir.
Okay. That's regarding electrolytes. Anything else?
So, serum creatinine will be raised because there is severe dehydration.
Okay. What is that called? Patient will be in a state of pre-renal
failure.
uremia.
Pre-renal
Okay.
uremia. Yes, sir.
Kidney is not as such affected, but the patient's urea and serum creatinine level will be all chronically obstructed patients with vomiting due to dehydration. They will have pre-renal uremia status.
Okay.
Urea will be elevated, but creatinine will not show much of elevation. That is pre-renal uremia. Yes. Anything else will be there?
That's it, sir.
Okay. Would you like to do a paradoxical acidosis? He says yes. That
Yes,
can be
paradoxical aciduria.
Yes. In liver function test, if you do you expect something in this patient?
So the ALT AST levels will be elevated.
In what condition? What is the reason for that?
So in maybe in duodenal ulcer conditions, it may be elevated.
No. That is hepatic damage. That is an advanced stage. Metastasis can produce such things. Number one. But even before that, the patient will go in for hypoalbuminemia. Okay. So proteins will be reduced. Serum protein. Okay. That's one component you will have to remember in general investigations. Right. Okay. Go to the next part of investigation.
Then we will do specific investigations, sir, which is ultrasound abdomen and upper gastrointestinal endoscopy, CECT, biopsy, barium, and diagnostic laparoscopy.
Okay. Right. What are the things you will see in ultrasonogram of abdomen?
Yes, first, we will do ultrasound, sir, where we will see the site of lesion, the extent of the lesion.
Okay.
We will see if there are any secondaries present.
Okay.
We will see free fluid if anything is present.
Yes. One other thing is nodal status you should observe. Okay. Evaluation of the primary, if possible, should be made, and secondaries in the abdominal viscera, various viscera like liver and other things. Okay. And as it is, importantly, nodes you should look for in an ultrasonogram of the abdomen. Okay. Right. What CECT you would like to do here? What are the types of CECT? Contrast enhanced CT.
Not sure. Iodinated contrast.
See, there is oral contrast, there is IV contrast. Two types of contrast can be administered and CT can be taken. Do you follow me?
Yes, sir.
One type of contrast is given orally. In that CT, you can clearly make out the luminal aspect of the pathology. Okay, if there is a exophytic lesion going into the lumen, whereas a intravenous IV contrast is also administered sometimes. So contrast is of two types. Okay,
Okay.
IV contrast, you will be able to see the nature of the tumor within the wall. Okay,
Okay.
intraluminal part you will be able to better delineate when you do a oral CT. So oral contrast CT, right?
Okay.
Okay. Then
Upper GA endoscopy is the actually
what
gold
are the
standard.
what are the things you would like to see
So
with
we
the
will see where the lesion is, sir, and how and what type of lesion it is.
okay,
It's polypoid or ulcerative, ulceroproliferative.
okay. Anything else you would like to see? Only that malignant lesion you would like to see?
We can also see if there is any presence of any ulcers. Then we can do a J maneuver and see if there is any lesion in the fundus.
Okay. Apart from lesion, you'll have to see the wall of the stomach interior.
With endoscopy, sir.
Yes.
So
How does
we
the
will
interior of the stomach look like in normal endoscopy?
sir, there will be ruges.
That exactly. So it's not only the lesion which you would like to visualize. When you just enter, you will have to see the OG junction and enter the stomach and look for the capacity and abnormal distension is there or not. You will have to see number one. Number two, the wall of the stomach should be visualized for assessing the normal rugosity of the gastric wall mucosa, right?
Okay.
What is a condition where the normal rugosity will be altered and some other abnormality may be there? Is there any condition where the rugosity may be lost?
So in chronic ulcers, there will be no rugosity.
What is it called? Can you specifically tell the condition where rugosity will be lost? Yes,
Malignant gastric ulcer.
Dr. Jemima is exactly writing. Kauri is telling. This is Linitis plastica. Understand? It's a leather bottle stomach, they call it. In Linitis plastica, the normal rugosity of the stomach will be lost. It will be like a flat wall without the folds, rugosities. This is one of the really important questions you should remember. The condition where normal rugosity is lost is Linitis plastica. And also in chronic atrophic gastritis, also the normal rugosity will be altered. Right? So when you put an endoscope, not only the ulcer, you'll have to look for all these things. Okay. So you will see the capacity of the stomach, distensibility of the stomach. You will see the rugosal, normal rugosity pattern maintained or not. Then you should go and visualize the cancer proper tumor and assess it. And anything else you want to do? It's a case of gastric outlet obstruction.
Yes, sir. So we will collect biopsy too.
Yes. Distal to the tumor, what you should look? The endoscopist will normally give in writing about that.
Distal duodenal normality, sir.
You will be able to visualize the duodenum?
The initial part, if there is
it's a gastric outlet obstruction. The endoscopist will usually give the duodenum cannot be entered.
Okay.
That is a confirmatory finding for a gastric outlet obstruction. Okay?
No. Okay, sir.
A cancer tumor may be there, or a exophytic lesion may be there. It could be there without causing obstruction also, right?
Okay. Okay, sir.
But the purpose of confirming gastric outlet obstruction, the endoscopist will essentially give the last wording as, after pointing out all these things, he will say the duodenum cannot be entered. That confirms the gastric outlet obstruction.
Okay,
so when you do an endoscopy for a gastric outlet obstruction, in this case due to gastric tumor, you should tell, I will put the endoscope, look for OG junction abnormalities. I will see the volume of the stomach, distensibility, normal rugosity pattern whether maintained or not. I will look for the malignant lesion, the nature, take a biopsy, and look if duodenum can be entered. Usually
Okay.
in gastric outlet obstruction, the duodenum cannot be entered. Okay.
Okay.
Right. Next.
Yes, sir. Then we will take a biopsy.
Yes. Is there a
Then
possibility of staging the disease by your endoscopy? Any other add-on facility to the endoscopy?
sir, ultrasound endoscopy.
Yes. Use the sonoendoscope can be. What is the advantage of that?
Sir, it will give the initial stagings for us.
You can layer by layer the involvement you can make out. Mucosal
Okay.
layer, submucosa, muscularis, and then up to the serosa and extraserosal, everything in a banded pattern they call it. Okay.
Okay.
When
Okay.
endo-USG is applied, the image will be displayed in a banded pattern. So each layer of the stomach you can clearly make out and see up to which layer of the stomach the tumor is extending. That is possible with the
Ultrasound
ultrasound
endoscopy.
endoscope,
Yes.
sonoendoscope, where exact staging of the tumor can be done. Right? You should be
Yes.
able to tell that. Yes.
Yes, sir.
Biopsy. Okay. Then.
Sir, and in barium meal, certain conditions cannot be visible in endoscopy. So for that, we can give barium.
What is the advantage of barium meal over endoscopy?
Not sure.
Endoscopy is a anatomical visualization of the lesion. Okay. Whereas barium meal gives an idea about the emptying.
Okay.
So you can give a barium meal and take pictures after a few hours after that, and what they call is a follow through, which is done 24 hours later. So barium meal also evaluates the functional or emptying capacity of the stomach. If it is total obstruction, barium meal will not be
Empty.
emptied from the stomach at all, or there will be very, very, very minimal. Residual barium will be there in the stomach still because it is not emptied. So, advantage of barium meal is apart from evaluating the primary tumor, that is best possible with endoscope. The emptying of the stomach can be well evaluated using barium meal.
Barium.
Okay, they
Yes, sir.
usually tell a follow-through film they call it. After administering barium meal, you take after 15 minutes, 1 hour, 4 hours, 6 hours, you repeat films.
Okay.
After 24 hours, they take one meal film which is called follow-through film. So usually in a stomach which empties, the follow-through film, there will be no residual barium in the stomach, everything will be empty. But in a totally obstructed stomach or subtotally obstructed stomach, the barium, residual barium will still be there even after 24 hours. Follow-through film distal contrast ரொம்ப இருக்காது, but it will be retained in the stomach. That is the advantage of barium meal. So nowadays they don't do usually, but the advantage if they ask you, you can tell this, right?
Okay.
Okay. Next.
Yes, sir. Then diagnostic laparoscopy.
Okay.
So it tells us about the we can stage with it, so laparoscopy, and see if there is secondary mets anything in the abdomen.
When do you pose the patient for diagnostic laparoscopy?
Sir, half an hour before the surgery.
Yes. It is always preceding the surgery. Whether your decision to do surgery is valid or not, you can decide. Sometimes when you do diagnostic laparoscopy, what are the aspects of tumor which can be best evaluated by diagnostic laparoscopy, or an extra advantage with the diagnostic laparoscopy? Can you tell?
Sir, CECT can miss almost 25% of liver mets and other secondary mets, sir, but diagnostic laparoscopy is more precise than CECT.
Yes, very small peritoneal mets which cannot be picked up by imaging can be done. Yes, peritoneal secondaries, Kritika is saying exactly those secondaries which are very small enough, which cannot be picked up by your imaging methods, can be visualized by your diagnostic laparoscopy. So when you put a diagnostic laparoscopy, first you have decided you are going to operate on a patient, but you put a diagnostic laparoscopy and see suddenly your decision may change. Okay, there may be some umbilication in the liver surface or small mets which were not made out by your contrast enhanced CT. or small seedlings in the peritoneum in the form of small peritoneal deposits may be there, or some malignant ascites which was not made by your imaging facilities will be visualized. All these unfavorable findings made out in a diagnostic laparoscopy will confirm that it's a metastatic disease where the surgery, the decision to do surgery should be revised. Okay.
Okay.
So, diagnostic என்னென்ன பார்ப்பீங்க அப்படின்னு கேட்டா liver mets which are not picked up by imaging, peritoneal deposits which are small enough not to be diagnosed by your imaging, and malignant ascites.
Okay.
These are all things which can be picked up with your diagnostic laparoscopy, right? Okay, next.
In the treatment, the surgery is subtotal
What is
gastrectomy.
other investigation? You have told general investigation, specific investigations. What is the third set of investigations usually you do?
Staging investigation.
Yes. So, staging investigation or metastatic workup, like called, to investigations to make out the distal spread of the disease. So, what are the things? You
So,
already put that here. Whole abdomen, chest also you should do.
Yes,
and the symptomatic other evaluation of skeleton may be done. Okay. If the patient is having a chronic headache with some seizures and other things, the CT of the brain also should be done. That is third set of investigation is investigation for distant disease or metastatic evaluation. Okay, right.
Yes, sir.
Okay, how will you treat the patient?
The surgery is subtotal gastrectomy with adjuvant chemotherapy.
You should say based on your investigations and findings. Okay. So if on after finishing my investigations, if the patient is not having any metastasis and the tumor is confined to the distal part of the stomach, okay. So there are various choices of treatment. Just like that, you cannot say I will do only subtotal gastrectomy. எந்த கண்டிஷன்ல subtotal gastrectomy பண்ணுவேன் அப்படின்றது சொல்லணும். Come out properly like that.
Sir, if the tumor is more than 2 centimeter and if there is lymph node involvements, and if the malignant growth is quite big from the distal part, I will do a subtotal gastrectomy.
Very good. If my investigations relieved that there is no metastasis and the tumor is confined to the distal part of the stomach, I will go ahead and do a. Yes, you tell your treatment is right.
Subtotal gastrectomy.
Okay. How will you reconstruct after doing? What is subtotal gastrectomy?
Sir, 80% of the stomach is removed, sir, and then we will do a reconstruction surgery. Billroth type 2.
Type
2.
Okay. Billroth type 2 reconstruction will be done. Okay, right. Followed by
adjuvant chemotherapy.
Adjuvant chemotherapy. Can you tell one of the chemotherapy agents which are given for adenocarcinoma?
Yes, sir. Ecrubicin, 5-fluorouracil.
Yes.
And cisplatin.
Okay, right. What are the other options of treatment?
Yes, sir. There are. We can do endoscopic surgery, sir. If the tumor size is less than 2 centimeter and if there is no lymph node involved.
We will come location wise. This one you are told it is situated in the distal part of the stomach where we will do a subtotal gastrectomy with Billroth 2 type of reconstruction, right?
Yes, sir.
Suppose if the tumor is located in the mid body or proximal stomach, what will you do?
We will do a total gastrectomy. And the reconstruction surgery is raw and Y reconstruction.
Why?
Reconstruction.
What is it called? Esophago?
Sir? Esophagojejunoscopy.
That's okay. Because I think someone has to mute themselves. Okay. So the whole of stomach.
நான் இல்லடா.
See, mute yourself. Yes. So the total stomach is removed. You will have to
Yes.
specifically tell that I will do a total gastrectomy followed by Roux-en-Y esophagojejunoscopy.
Jejunoscopy.
Okay, right.
Yes, sir.
This is what you have told a location that is a advanced cancer or a cancer which is exophytic.
Yes, sir.
Okay, so what is this procedure for early gastric cancer? Just now you have told me before.
The subtotal endoscopic surgery.
What is the name of that procedure? Tell me.
There are two procedures, sir. One is endoscopic mucosal resection, and the other is endoscopic submucosal dissection.
Yes. So this is when very early gastric cancer is diagnosed. In usually screening procedures, this is possible. Okay. Once
Yes.
the patient has come with complaints, the possibility of this early endoscopic resection is not there.
Okay, sir.
The patient, usually the patients who are eligible for endoscopic mucosal resection are those patients picked up by screening endoscopy.
Yes, sir.
Okay, so
Yes.
this is not possible in our scenario, right?
Okay. Yes, sir.
Right. This is what you have told about the management of a operable cancer, right?
Yes, sir.
What are the other scenarios where you will have to take decision?
Yes, sir. If there is any secondary myths, and if there is distant peritoneal spread, or ascites having malignant cells,
Yes.
or if there is any structures which is not operable, which can't be removed, which has cancers, then we should do palliative care.
What is the palliative surgery for gastric outlet obstruction with CS stomach?
Gastrojejunostomy, or we can keep a stent.
Gastrojejunostomy. What gastrojejunostomy?
It's anterior gastro tube.
Yes, the procedure done for CS stomach is usually anterior gastrojejunostomy. Okay, right. So stenting is an endoscopic procedure which is done by endoscopists usually. It's not done by surgeons. But what is the difference between operability and resectability? You told no, there is an obstruction mid-distant stasis. You will do only a
palliative
bypass.
Yes,
is there a role for resection and diversion?
Yes, sir. We can actually remove it and to just extend the life of the patients.
Which is better?
Removing this and extending, I guess.
Yes, it doesn't extend the lifespan of the individual, but it avoids the complications which will be following by retaining the tumor. Okay.
Okay.
So see, there are two scenarios. You are palliatively removing the partial resection and bypassing it. In that case, you are removing the tumor mass. If you leave it behind, though you have bypassed, it will bleed and some other complications will be there. Any of the lifespan of the patient will not be extended, or there is no scope of cure in this patient, but a better palliation.
Okay.
Suppose you do only a bypass by retaining the tumor, the patient will bypass the obstruction, but the tumor will bleed sometime later. It will necrose. And the patient will have need some other interventions which are not needed. But anyhow, the lifespan of the patient will be similar. So whenever possible, so that's called a operability and resectability. Operability is a tumor which is done with a curative intention. Right? Operate panni, bypass panni, adjuvant chemotherapy if you give, it is aimed at curing the disease. Whereas resectability is not essentially offering cure for the disease, but relief from the complaint, palliation, right? So resectability and operability, you should understand the difference, right? Okay. So then you should give a palliative chemotherapy should be given. Okay. So if it is not operable and still stenting is possible, what are the type of stent, you know?
No idea.
It is called self-expanding metal SEMS, they call it. SEMS, self-expanding metallic stent. Any other endoscopic palliation is possible apart from stent?
Not sure, sir.
You can create a tunnel inside the obstructing tumor.
Okay.
Laser,
Okay, sir.
ablation of the tumor. Okay, so a laser ablation where a tunneling can be done within the tumor and the obstruction can be given. One is deployment of stent, the other is laser ablation using an YOG laser. Okay, so that's a possibility, right? So this is a from our undergraduate level, this is the amount of treatment needed for gastric outlet obstruction due to gastric carcinoma, right? And
Yes,
background anatomy about and other surgical theory about gastric stomach, I think you should have all read. Okay, what is the Lawrence classification? You got some more slides to display, Gokul?
Yes, sir. I have a few surgical management slides here. So this is
Okay.
the investigation. This thing, sir, algorithm.
Yeah. Okay.
And this one is the tumor staging, sir. So
T1 is what is Lawrence classification?
Okay, sir. The Lawrence classification, it is for early gastric carcinoma.
Okay.
So and it is divided into protruding, then superficial. In superficial, it is elevated, flat, and depressed. Then the last type is excavated.
Okay. What are the two broad types of gastric carcinoma regarding the etiology?
So, like the environmental.
Which type of gastric cancer is mostly determined by etiology? I mean, environmental things.
So, H. pylori infection. It is mostly due to the environment.
Tell me the terminology of two types.
Not sure.
Genetic type cancers are called gastric type. The other one is called intestinal. That is a broad classification, right?
Okay.
Gastric cancer is broadly of gastric type or intestinal type. Gastric type cancer is more often found in the proximal part of the stomach, and genetic factors are more determinant than intestinal type, where it is mostly of distally placed, and the environmental factors like food, toxins, the others play a role. So this classification you should immediately tell: gastric type and intestinal type. Okay. Prognostically, which is better?
So intestinal type is better.
Yes. Okay. Gastric type is more detrimental compared to the intestinal type. Okay. So intestinal diffuse, they have told, right? Now, the gastric outlet obstruction is the main pathology here. We have made a diagnosis of gastric outlet obstruction due to a carcinoma stomach. Okay. So we'll go to the other side that also need to be discussed. Okay. Without a gastric cancer, due to benign cause also GOO can occur, right?
Yes, sir.
So in that case, if you get a case, you should obtain history like that, and history of periodicity pain you should essentially give in your presenting illness. Patient will usually give history of periodicity pain, namely the patient sustaining or developing pain at fixed intervals like 4 months or 5 months once, for which the patient will approach some local doctors, get treated and get momentary relief only to recur after the gap of time. That is called periodicity pain, right?
Yes.
So what is the treatment for gastric outlet obstruction due to benign cause? What is the reason for that?
Sir, if it is due to the duodenal ulcer causing cicatrization, we can do. Yes, sir, we can do a truncal vagotomy and gastrojejunostomy.
Okay. Right. What is the jejunostomy which is done there?
It is posterior jejunostomy.
Posterior gastrojejunostomy is done. So you should remember truncal vagotomy with posterior gastrojejunostomy. Any other improvisation of vagotomy is there?
Yes, sir. We can do a highly selective vagotomy, which does not require drainage.
Yes. If you do a highly selective vagotomy, you do not add a drainage procedure along with that. Okay.
Yes,
right. So, what are the complications of your vagotomy?
so there can be a bile stasis.
Okay.
There can be gallstones.
Okay.
And due to less acidity, hypoacidity, there can be bacterial infiltrations in the stomach.
Mm. What are syndromes associated with that?
I'm not sure.
Dumping syndrome, you heard of it?
Yes, sir. Early dumping syndrome and the late dumping syndrome.
You should remember. And delayed gastric emptying is one of the main things which you should know about a complication of your drainage procedure. So, truncal vagotomy with. So, okay. Right. And regarding your drainage procedures, is there any other option apart from gastrojejunostomy?
Yes, sir. We can do a pyloroplasty.
Yes. Instead of bringing a loop and bypassing it, you can do a pyloroplasty, which is also a part of draining procedure, which is usually accompanying a truncal vagotomy. Okay.
Yes, sir.
Right. How many vagus are divided in a vagotomy?
Sir, anterior vagus can be removed, sir, and posterior vagus we can actually keep.
They remove both vagus only. Okay. So anterior vagus is usually placed in the left side. It is always called left vagus. Posterior vagus is usually the right vagus.
Right vagus.
Okay. So is there any other cause for gastric outlet obstruction?
Yes, sir. It can be pyloric stenosis.
Two common problems, right? One is the malignancy, which is gastric cancer causing outlet obstruction. Other one is a cicatrized duodenal ulcer causing a thing. Okay. So meanwhile, you should also be able to tell the endoscopic findings of a benign gastric outlet obstruction, where you should tell on putting endoscope, the stomach is distended, but still the mucosal pattern will be retained, and you will be seeing a pre-pyloric region. You are at the first part of the duodenum, you will be able to see an ulcer which is cicatrized and narrowing is present. The endoscope cannot enter the beyond the D1. You should tell endoscopic findings. Okay, right. Okay. What are the other causes of gastric outlet obstruction?
So there can be pyloric stenosis.
Yes.
There can be cancers of pancreas.
Exactly. So head of
pancreas.
Cancer, head of pancreas is one of the reasons for gastric outlet obstruction. Is there anything else?
Annular pancreas.
Yes. Okay.
And there are psychogenic conditions like trichobazar and phytobazar.
Yes, where the ingested contents will go and make a cast the gastric outlet area. Sometimes it can go up to full of stomach also it can occupy. Okay. Yes, then gallstone disease can cause sometimes?
Yes, sir.
So eroded gallstone can get impacted there and very rarely present as a gastric outlet obstruction.
Yes,
okay.
Sir. Yes, sir.
So there are many other causes of vascular causes, but they are more distally placed. The proximally placed things are more commonly, as we said, the conditions here. Okay. So I think that any doubt you can just ask. The theoretical part, that is many. Okay, about the pathology and nodal stations, I think you have to
Yes, sir.
And Borman's classification, Mink's classification. There are one thing. Okay, so
Yes, sir.
and I say you have told D1, D2, D3. Usually,
Yes, sir.
what is the type of dissection you do for a subtotal gastrectomy?
Sir, generally we will do D1, sir, but D2 can be done.
So the oncologically accepted resection is D2 resection. So you say, when you say subtotal gastrectomy with D2 lymph nodal dissection with Billroth 2 type of reconstruction followed by adjuvant chemotherapy should be your answer. Okay, right.
Yes, sir.
Is there a load for sentinel node sampling here? Have you heard of it?
No, sir.
Yes, in that's a recent advantage where even in gastric cancer, if your imaging tells that the nodes are not palpable, there is a role for lymph node sampling also. There are papers or publications which have come up. Okay, sentinel node sampling has been done in cases of CS stomach, which they do have a role in CS stomach. Okay,
Yes, sir.
understand that. Okay, I think we'll finish with that. Any doubt, you just can. But mostly the theoretical part, they can ask anything. So the whole of about CS stomach, you will have to study fully for the background theoretical discussion. The way you should present and take forward the thing I have discussed. Right?
Sir,
Okay.
sir,
Yes, please.
sir, a doubt, sir.
Yes.
Sir, these gastric outlet obstruction cases usually present with anemia, sir. Is
Okay.
it okay to operate on a patient with low hemoglobin, sir?
That part I think I will miss it. How will you prepare the? We'll make a discussion of that now.
Yes, sir.
Okay.
Okay, sir.
So I'll come back to Gokul. How will you
Yes, sir.
prepare the patient for surgery? You are finishing your thing and coming to the ward. There's a case of gastric cancer. What are the things you will have to take care in preparation of the patient? That will also answer this question which our friend has posted now, right? What is the pre-operative preparation of a gastric outlet obstruction patient? What are the things you will correct?
Sir, we should give fluids, electrolytes.
So that I don't know whether I have told how will you operate on the patient. I have told 5 Romans. Do you remember that? We'll start from that. We'll get the patient anesthetically fit. Okay. Do you hear me?
Yes, sir.
So we'll obtain the anesthetic fitness. Second one is, what is the type of anesthesia you will use for this patient? It's a major surgery. What anesthesia will give?
General anesthesia.
Endotracheal general anesthesia, you should tell. Okay. There are two types of anesthesia. Even IV anesthesia is called general anesthesia. But this is a prolonged surgery where the patient has to be under your control. So that is called endotracheal general anesthesia. Okay. So you'll get the patient anesthetically fit under endotracheal general anesthesia. The position of the patient is supine position. Okay.
Okay, sir.
So the incision is midline incision involving the upper abdomen. Okay, upper midline incision up to the umbilicus can be made. So, okay, what are the things to be observed in pre-operative preparation of the patient? One by one, you tell me. Gokul?
Yes, sir. Sir, for few days before surgery, we should not allow the patient to take any solid foods, and only we should maintain
Very
liquid.
good. First part is ask the patient not to consume anything. Okay. you will keep the patient nil oral for 2 days.
Yes, sir.
Accepted. Some people keep it for 1 day. Some liquids only they give. Some people for better post-operative results, they keep the patient nil oral for 2 days. Yes. If you put him on nil oral, what else you should do?
Sir, before the surgery, we should do saline stomach wash.
Okay, so you put the patient on nil oral, put a Ryle's tube in situ, and give saline wash twice a daily, and remove all debris so that the mucosal cleansing will be there, edema will be minimal. Okay,
Yes, sir.
that is one thing. Yes, you will correct few things one by one. You tell me. The
Sir,
patient,
we will.
yes, patient was vomiting all the while.
Yes, sir. He will be dehydrated, so we will give fluids.
Very good. The patient
Electrolytes.
yes, first one you will correct the dehydration. The patient will be in a state of pre-renal uremia. We have already told. So sufficiently the patient should be dehydration should be corrected. Correction of dehydration. First one is nil oral Ryle's tube aspiration wash. Second one is correction of dehydration for by giving sufficient IV fluids. Okay, then.
Yes, sir. So then we should correct the hypokalemia which is present.
Yes, all dyselectrolemia. Okay,
Yes,
all components of dyselectrolemia, namely hyponatremia will be there, hypokalemia will be there, and alkalosis. All these things should be corrected. Okay,
yes,
by
sir.
giving extra saline and potassium supplements, and the alkalosis also should be sufficiently corrected. Okay, then. Our friend was asking one question, no? Anemia.
Yes, sir.
Yes. So you should look for the hemoglobin part. It's not only the gastric surgery. For any other surgery, the anemia needs to be corrected. In this case, the anemia should be corrected appropriately. You can give iron sucrose if it is very minimal, or if the anemia is very severe, you will have to make a blood transfusion. Without correction of anemia, going ahead with surgery is not advised, because the healing will not be very good. The patient post-operatively will develop complications, desaturation, everything is possible. So the correction of anemia is mandatory. You should correct dehydration, you should correct electrolyte disturbances, you should correct anemia, and then what? The patient will also be in a state of hypoproteinemia, right?
Yes,
The patient was vomiting, malnourished, not taken something. So the albumin levels should also be assessed, and if possible, the albumin correction can also be given by intravenous albumin supplementation. Okay, it is possible. Human albumin is available, you can give it, or some people give astamine, which is another form of improving the things. So anemia correction is not only specific for this surgery. For any other surgery, the anemia needs to be corrected. Then only you should take up the patient for surgery, right?
yes, sir.
Okay. Any other doubt? Yes. It is all right. I think we will wind up. Okay. Thank you. Quit பண்ணு சார். சாரி சார், உங்களை வேற டிஸ்டர்ப் பண்ணிட்டேன். ரூம்ல உட்காரவே முடியல சார், ரொம்ப கஷ்டமா இருக்கு.